Rapid sequence intubation is an airway management technique that induces unresponsiveness and induces muscular relaxation. It is indicated for a patient with severe airway or ventilation compromise and a patient with a GCS of less than or equal to 10. The important things to consider when entering the scene of this patient is the dangers. Is it safe to enter the scene? How far are we from a major trauma hospital? And also where the distance or time from an RSI trained ICP, which will possibly be needed in this case. Our patient has suffered a fall from a building and has a boggy large patch on the back of his head. It's occiput injury. Our patient has all the clinical features of a TBI. He has a decreased LOC and decreased work of breathing. He's holding his breath. This means he does qualify for RSI. We are making sure that we are preventing secondary brain injury and preventing that airway and breathing system breakdown. This is why RSI in this case will be indicated.
Hi, my name is Kimberly and I'm going to be doing my RSI osce. So I'm suspecting my patient has a TBI. He's had a fall, he has a boggy patch on the back of his head. He's got a decreased GCS. The first thing I'm obviously going to do is my ABC, so looking in the airway, is it clear, is there vomit, blood, whatever. I've got the suction unit right here with me if I need that. His breathing, according to the scenario, he has a rest rate of 12 breaths per minute, but it is irregular. He's holding his breath and grunting, so I have some concerns about his breathing. I'll be wanting to get some oxygen on him. Because of this, I will be using a reservoir mask to begin with at a flow rate of 10 litres per minute. So I'm just going to attach it on now. So we're going to assume that's running at 10 litres a minute on the oxygen bottle. And I'm assessing his circulation, what he's looking like hemodynamically, and I'll be getting my offsider to put in, or me, I'll be putting in 2 large bore IVs if I can, or I can go for IO if that is not available to me. Because my patient is combative and has got a decreased GCS, he is extending, he's confused and combative. He's definitely got a GCS of below 10. I'd calculate that score. I'll put it somewhere on the screen here. And then because I'm concerned he's got a GCS of 10 or below, and I'm worried about his airway and his ventilation compromise, I'll be calling for an R50 for RSI. So in preparation, my RSI ICP wants me to prepare for intubation, rapid sequence intubation, and he'll be 10 minutes away. So I'm just going to prep the patient. I'd get a full set of vitals anyway, which my offsider or I would be doing.
Push and neck.
Put the monitor in manual mode and start attaching my ECG stuff. So I've attached my 3 lead and I'm putting SpO2 on, which is super important for this guy. Blood pressure, SpO2, ECG, all of that. And I've got the monitor here nice and clear where I can see it. This one. Oh, there we go. There we go. So I'm not sure if you can see, but on the monitor he's in a normal sinus rhythm with a heart rate of 50 beats per minute. So Now I'm constantly monitoring his vitals and reassessing his ABCs because they could become compromised. I've put his head in a head kind of tilt chin lift situation in the sniffing position. I've packed a towel under his head and I'd pack towels under his shoulder. To prepare for RSI, I'm going to put some nasal prongs on the patient. My nasal prongs set up and they're ready to go for supplementary oxygen when the RSI takes place. Right now we're pre-oxygenating the patient with the reservoir mask. We're putting a Thomas tube holder under the head for the ET tube. So we're preparing that. We'll get our bag mask valve out. We'll also put the ET CO2 on there in case we need it. Well, we will need it. We'll put the ET CO2 on because we're going to need that for when intubation takes place. We're also going to prepare some fluids. So we're going to prepare the line. This is just 500 mils, but I'd use a litre of saline, and that's all prepared, ready to go. It is important that we have oxygen and fluids there ready to go, or like oxygen attached at the moment to prevent secondary brain injury. Secondary brain injury can be caused by hypoxia, hyper or hypoventilation, or hypovolemia. So another thing we're going to need is the suction unit to be readily available to us. We're just going to place a suction catheter under the shoulder of the patient, just so that if the ICP needs it, it's there ready to go. I am going to then do a full set of vitals, keep monitoring the patient. The next thing I'm going to do is I'm going to kind of declutter the area, remove anything that we don't need, kind of keep everything nice and tidy and ready to go. Move all that away. We want both sides of the patient to be accessible, so that's all good there. We can see the monitor, got the oxygen and the suction unit close by. I'm then going to do the RSI checklist. So attach nasal prongs for supplementary oxygen, which we've done. We've pre-oxygenated the patient for 10 minutes before the ICP arrives with the reservoir mask. We've attached ECG, NIBP and SpO2 monitor. We've got the ETCO2 tube on. We've positioned the monitor where we can see it, leaving the space to the right of the patient's head for the intubation roll. We've gained access in 2 sites. We've done that. We've prepared a saline for fluids. We've placed a towel under the head. We've placed an ET tube holder under the head. The suction unit is, well, we've tested that it's working. Yeah, and we've made it go right up to 500 milligrams of mercury, and we've got the suction catheter on there under the shoulder. We have got the manual BVM mask with PEEP attached. We've obtained a full set of vitals. We've prepared the area. The patient is in an ambulance, but if we were, we'd just maintain a nice clean working area, only have the things that we need out. We'd consider moving the patient to backup, and yeah, that's all for that. If the patient was combative, we could, which he is, we could give him morphine to settle him down a little bit. It would be safer for him and us if we did. We could give between 2 and 5 milligrams of morphine IV.
You may be asked to perform a burp maneuver by the ICP. This is laryngeal manipulation. You hold the cricoid cartilage and you perform a backwards, upwards and rightward pressure maneuver. For a difficult airway, a bougie assisted ET placement may be necessary. The ICP will insert the bougie into the airway and maintain visualization of the bougie and the vocal cords. You may be asked to advance the ET tube down the free end of the bougie and just run your hands down the bougie as you advance the ET tube on. It will need to be passed over the vocal cords at a 90-degree clockwise turn, and then the ICP will confirm placement of this, obviously with end-tidal CO2 and a measurement. Shall the intubation fail the first time, the failed intubation drill will be utilized, which I have right here. The patient will need to be manually ventilated with an OPA or NPA, obviously at a rate 1 breath per 6 to 8 seconds. It's important that you don't hyperventilate the patient. The ICP may try the process of intubation again using a bougie, which is maybe a chance that you may have to assist in the ET tube placement, and it will be checked with end-tidal CO2 for confirmation. If that fails as well, you go back to a basic airway management, again using an OPA or NPA and manual ventilations. However, if you are unable to ventilate for some reason, such as trauma to the airway, etc., cric may be an option there.